Welcome to the Poisoning Podcast, where we explore the people and the policies shaping our response to the overdose crisis. Today's guest is Dr. Travis Harker, Chief Medical Officer at Appledore Medical Group, serving patients across New Hampshire's seacoast and working closely with the Portsmouth Regional Hospital and Parkland Medical Center. Though on today's show, Dr. Harker is appearing in a personal capacity. Dr. Harker's leadership spans from launching New Hampshire's first joint health plan to spearheading the Zero Left Opioid Initiative, which trained over 200 providers in safe prescribing and made it easier for communities to dispose of unused opioids. As a past president of the New Hampshire Medical Society, he's been a strong voice for mental health, Medicaid expansion, and prevention-focused care. We'll talk about emerging drug threats, how medical systems can adapt, and what it will take to protect communities in an era of rapid change. Dr. Harker, thank you for joining us on the Poisoning Podcast.
Hi, Erin. Thanks for having me.
Of course. So I would like for you to start with telling us, for those who might be unfamiliar with your work as a physician, how it intersects with this current overdose crisis.
So I'm a family doctor, and I have patients that I see. I'm also an educator. I teach medical students and resident doctors and preparing the next generation of physicians. And then I also help lead our medical group here. And so I see the opioid crisis from three different lenses. One, with my direct patient care, when I see my individual patients who are living with substance use disorder and working through that. I see it as we train our next generation to be prepared to meet our patients and our community needs. And I see it as a health system as we're working together with our emergency department, the hospital, and our other specialists as we try to together have a collective impact on this opioid crisis.
Wow, that's a lot of range there, but it shows you how important it is. So we met in Portsmouth, New Hampshire last week, I think, if time flies, and you served on a panel about emerging drug threats at the National Association of Attorneys General. And I was looking at the agenda before the conference, and I was a little sad because there's a drug in my community, Nitazines, that most people don't know about, that has increased our overdose death, but it wasn't even listed on the agenda. But you in the first panel brought it up on your own. So what were some of those takeaways for our listeners from that discussion on the emerging drug threats?
Well, it was a great panel, and I was glad to be part of it, representing kind of the medical perspective. I was also accompanied by someone from law enforcement and someone from a research community who was helping us to understand the opioid crisis. And the big takeaways from that was that we need a collective action on how we approach the opioid epidemic. And we need data to understand what's actually happening in our communities. We need treatment options, and then we need law enforcement to help incarcerate if needed, but also to use drug courts or treatment courts to help people get into recovery. The emerging drugs that we talked about were fentanyl, methamphetamines, which feels like it's hard to say that they're emerging because they feel like they've been here for quite some time.
Right.
But then we've also talked about xylazine, and we talked about the nitazines. And the nitazines, which you mentioned, are a new form. Well, they're not new. They're new to our communities, but they were developed in the 1960s as a pain medication that never got approval through the FDA, but is now emerging and is one of the most potent opioids out there. If you imagine, fentanyl is about 100 times more potent than oxycodone, and then nitazines are 40 times more potent than fentanyl. So as oxycodone, we measure in milligrams, and fentanyl is in micrograms, and so to have highly potent doses, even smaller than micrograms, for the nitazines is extremely dangerous. When people use opioids or illicit substances, they inject what is given to them, and there's no quality control. And as they dip into a bag and they use their product, they may have an extremely high dose of something that is extremely potent, which would result in them to stop breathing. And would necessitate a resuscitation. And about 10 years ago, we were seeing mostly things like OxyContin that people were using, and it's kind of shifted more into fentanyl. And those were really responsive to naloxone, which is a life-saving treatment that's available that people can use in a nasal spray or an injection, an intramuscular injection that can be life-saving for people who are overdosing on pure opioids. What we're finding as fentanyl doses have gotten higher and higher, and the nitazines are higher and higher, naloxone is still effective, but you need more doses of it in order to combat the potency of the opioid that they are injecting or using.
So 2 doses in a box is not enough for some of those higher level drugs.
That's correct. So we need to continue to blanket our communities with these life-saving medicines because they can happen anywhere. I mean, I've read stories where people are at the barber shop and they go unresponsive because they dosed before they got a haircut. Or we've seen it in emergency departments and people go to the bathroom and use, and then we find them unresponsive in the bathroom. So we need to have naloxone everywhere if we're going to treat this appropriately.
3 different types right behind me here.
Perfect.
I'm a big fan. I agree. I think it is universal. Well, it's mostly accepted as a medicine now in the general population, whereas it was very not accepted several years ago. But I still don't think it's in places it needs to be. For instance, this spring, we lost several teenagers in my area due to nitazine-laced pills, Adderall, Percocet, etc. These are all illicit pills. And I have to be honest, doctor, like I had to tell some of my elected officials about it. They weren't even aware. These were high school students. I don't think parents were receiving naloxone. They have to go and find it. And while it's over the counter and you can get it at the local recovery center in the next county over for free, the small box behind me is $77. And they only had 2 at my local pharmacy, and I purchased both of them. And then most normal average citizens aren't really comfortable going to a recovery center to get it. So if Erin DeLullo is elected and charged, it would be given to every parent of a high schooler. It would be distributed to every college student. I just don't think the saturation levels are where they need to be right now.
Well, I'd vote for you for that campaign. So that would be great to have that naloxone everywhere. I know, it was 7 or 8 years ago now that I spoke at a local Rotary, and we did a demonstration on how to administer it, just to help raise awareness on 1, that the medication is life-saving, and 2, that it's easy to administer, that anyone can do it. You don't need to be a doctor or a nurse. It's super easy to do, and it's life-saving. So I think the more that we can get out in the communities, have it accessible, and then we need to find ways to make it financially accessible as well, because a lot of people don't have $70 to throw around on something like this.
Price is too darn high, and it shouldn't be that high. I would like a congressional investigation into that. So back to your medical perspective. In the ER, there have been stories where people will come in, they've overdosed, the ER has saved them with naloxone, but then they're, I guess, allowed to leave early, but the naloxone wears off. What rules should be in place to keep an overdose patient in the ER or admit them to the hospital longer? And have you heard of those type of situations?
So I've not seen that in New Hampshire, at least not in the past 5 or 7 years. I think some of it is around awareness. I don't know that we need like a specific rule that you need to stay in the hospital for so many hours. But I do think, physicians and nurse practitioners and PAs all want to do a really good job.
Sure.
And so if they understand that the drugs are changing and that you may need to dose them again because of what's in the community, I think that kind of information is really helpful for them to do the best practice. Because if they're treating it as if it were just a straight fentanyl overdose like they did 5 years ago, they might miss something because they don't know that there's something else that's more potent laced in there that could be causing another problem after they discharged. So I think just general awareness about what's in your community, and as we talked about in the panel, is very, very localized where the drugs, what the drugs are in your community. And so having good information from researchers, what is happening in our communities, will really help our frontline providers provide the best treatment. And so if we know that nitazines are in our community, we're going to hold on to those patients longer to make sure that they don't get subdued again and go unresponsive and stop breathing. I think if we know that it's not in our community, maybe our practice is a little different. But we need to treat each patient based on the risk factors that we see for them individually, but also within our community.
That's really smart about the local approach. But then I also think the local approach needs to be shared on a larger level, because if we're seeing nitazines in the eastern panhandle of West Virginia, that might mean 50 miles north of us might be seeing them soon, or 50 miles west.
And I guess what I mean by like locally, it's not just at that local hospital, but regionally. So like in New Hampshire, we haven't seen much of the xylazine that I mentioned earlier, which is a tranquilizer that they use in veterinary sciences. We haven't seen a lot of that causing major problems, but it has been found in drug seizures mixed in with fentanyl. In Philadelphia, for instance, they've seen a lot more of it, and they've seen a lot more of the negative effects from that. But in New Hampshire, as a state, we haven't seen a whole lot. So regionally, that's not been a major player for our patients, but it's good to have awareness of that because things can change really quickly.
Right. You're far, but you're not that far from Philly.
Yeah.
So let's talk a little bit about the xylazine and what it does to a user.
So xylazine is a tranquilizer. They use it in veterinary sciences to calm animals down when they're going to do a procedure. And the xylazine we're seeing on the streets is not being stolen from veterinarians' offices. It's coming from China. People who are manufacturing these illicit substances can get them can get xylazine very inexpensively from China, about $20 for a kilogram of that, and then they mix that with micrograms of the fentanyl or the nitazines to have a cocktail that is complicated, that causes profound sedation. And the xylazine is not responsive to naloxone. So naloxone is life-saving for fentanyl, but for someone who's overdosing on xylazine, we just need to provide supportive care. Sometimes we need to intubate them, provide oxygen, give them fluids, and keep them alive until the drug can get out of their system. There's not a reversing agent. One of the problems that it also causes is what we call vasoconstriction, or a tightening of the blood vessels. And there are many medications or drugs that can cause tightening of the blood vessels, and nicotine is one of those, and it's a mild vasoconstrictor, or a tight that shrinks down your blood vessels, and that's why smoking causes high blood pressure. But the xylazine is so much more potent than that it can actually clamp down the blood vessels completely, where blood flow stops going to the area where someone was injected, and it can cause ulcerations and skin death so profound that people sometimes need amputations because too much of their arm or leg has died.
It's just frightening. And so xylazine has a veterinary use, but not a human use, correct?
Correct.
In medicine. Fentanyl is a good medicine when used in the right setting by a doctor in a hospital. I believe it's even used in, the epidurals?
Yep. So we use it in a variety of surgical operations. It's good in general in the hospital, because if you're having surgery, it comes on, it's very effective, and then it goes away relatively quickly. And if you're using it for a surgical procedure, that's what you want. You want the medicine to numb you up while you're in the middle of it, but then you want it to go away and not linger and cause a lot of problems afterwards. And so in the hospital, we can control that very well, and we have trained professionals, anesthesiologists who are trained to do it, to use the medication with our patients, and they do it in a very, very safe way. When it's out in the community, there's no quality control on dosing. There's no monitoring if we're giving too much or too little. It's just people are taking a gamble every time they use, because there's no way to know actually how much of the drug is in what they're about to use.
And nitazines, does it have a medical use?
Nitazines don't. So they were developed in the 1960s, and they were not approved by the FDA at that time. And they've kind of reemerged as the opioid crisis continues to grow, and dealers are looking for other ways of pursuing that high and mixing in other synthetic opioids with their product for their customers.
So it's not even approved for medical use, folks. Don't get near it.
I wasn't familiar with it until recently when I had some conversations with the state medical examiner. And you mentioned in your community there are a number of people who weren't familiar with it. And I'm not surprised by that because it's not something that we learned about in medical school. It's not something, because it's not an FDA-approved drug. I mean, I went to medical school a number of years ago, so it's been a little while. But it took the medical examiner saying this is starting to emerge as a problem for it to get on our radar.
Well, I will applaud you from that panel last week. You started and said Nitazines, and then later in the day, and talked about it and the importance of what's going on in certain communities. And later in the day, there was a panel of just law enforcement officers working better together, so DEA, FBI, and they talked about Nitazines. So you did what I was hoping without even having met me. So thank you. Got the conversation repeatedly going throughout the day because we don't know where it's going to go next. And it's so hard to know what the bad guys are doing. That's why they're effective.
Yeah, and more knowledge is power, whether it's for us on the treatment side that we need to treat people longer and with more doses of naloxone, or in the community to say, you know, we knew that OxyContin was dangerous and fentanyl's more dangerous, and then now there's something that's even more dangerous out there on a prevention level. Like even the smallest amount of this can be lethal. And so I think getting that out in the community on a prevention scale might help people make different decisions if they're contemplating using illicit substances.
Or have loved ones prepared with the naloxone products in case they fear someone might make a wrong decision.
100%.
So let's talk about emergency rooms and what you're sort of hearing and seeing. Psychosis, polysubstances. What is the trend in your area right now?
Yeah, so I would say going back about 10 years, we would see people come in unresponsive. There'd be a beep in the parking lot. We'd come out, we would find someone there that would be unresponsive. We'd bring them in, give them naloxone. They would recover. We would get them either into treatment or sometimes they would leave. But we had at least the opportunity to talk with them when they were lucid after they'd come back from being unresponsive. More recently, we're seeing people present with acute psychosis, behavioral problems, more combative, really kind of out of their minds. And it's really this combination of these synthetic agents, such as the fentanyl along with the xylazine and the methamphetamines. So the methamphetamines produce a lot of psychosis. They really ramp up the brain. And they're in the same family as things that you mentioned earlier, like Adderall, that are commonly used for people with attention deficit disorder. And they're very effective in that regard. But the methamphetamines are much more potent. They are also much more dangerous, and they have a much higher risk of causing psychosis and an altered sense of reality. So when they come in, rather than being there just for a day or two if they have an opioid overdose, people are spending a week in the hospital, and we're needing to get psychiatrists involved because it's hard to know, is this a medical psychosis that's something that's not related to drug use, or is this something that's related to drug use? And sorting out like how do we treat these this presentation is really challenging. So they may spend a week in the hospital. Sometimes it's in the emergency department where they're having to board because the hospitals are so full. And sometimes they get admitted. And sometimes the altered sense of reality can last up to a month after the use of some of these combination synthetic drugs. And that's really worrisome because it's hard to keep people in the hospital for a month. And oftentimes we don't see that. And it's also hard to rationally talk about treatment options when someone is not in a good headspace where their sense of reality is not what is real.
I can't imagine having to treat someone who's in psychosis. You can't rationalize with them. Wow. So are there systems in place for frontline providers like yourself, first responders, doctors, that help them deal quickly with the new data and trends that are happening in the illicit drug market?
So there's not anything that's really robust and useful in a real-time basis. There is some retrospective data, and our hospitals have been part of this data collection where they've tracked since I think 2017 drug screens in our emergency department. So we would see what drugs are popping up positive on a drug screen on individuals that present in our emergency department. The data is de-identified, so it's kind of anonymous, but we were able to see trends that way by pooling our data, and we can see that about a third of the people coming into our emergency departments who have a drug screen test positive for marijuana. So marijuana has had a huge increase as the legalization efforts have gone across the country on that. And the thing that we're also seeing is that most people who screen positive on one substance are screening positive on multiple substances. So they'll have marijuana, they'll have methamphetamines, and then they'll have fentanyl. Or they might have benzodiazepine. So there's a kind of these cocktails that are happening. And this retrospective data, looking backwards, can help us understand where we're going, but it doesn't tell us where we are today. And so I think having more real-time data, I think an opportunity would be to pair data with law enforcement. As they do drug seizures, they test the product that they seize, and they can tell us what is in that. And so we know from law enforcement in New Hampshire that xylazine is present in a lot of the fentanyl that people are buying. But we're not seeing the profound negative effects that they are seeing in Philadelphia or other parts of the country. But if we had that data, that may help us understand in a more real-time basis. So if they did a drug bust yesterday and they found that these were the drugs that were present, sharing that with the emergency providers would be really helpful, I think, because then it might shape our approach to what we're doing and how we're approaching these patients in our communities.
No, I think that's a great idea. So how do you view the role of the medical system, not just in treating overdoses, but preventing them?
So I think any health system is foundationally based on a strong primary care network. And so we need to make sure that people have access to good primary care. Part of routine health, part of my practice is talking about healthy behaviors. It's eating right, it's exercising, it's sleeping, and it's avoiding toxins like nicotine, alcohol, and other illicit drugs. And I think having that be a foundational part of our community and our culture, that we talk about things, is really important, from the pediatric well child visits all the way into adult and older adults. I can't tell you how many older adults have been experimenting with marijuana in my community because they say, oh, I want to see if it'll help me sleep, or I've got some aches and pains. And I think there's a misunderstanding of how benign they think it is. And for many people, it doesn't cause problems, but for many others, it does. And so my job as a prevention specialist in primary care is to help people understand what those risks are so they can make the right decision for themselves.
I think the public views marijuana like the marijuana of the 60s and the 70s, not what it currently is today. So what do you think the difference is in the strength of marijuana past to present?
Well, kind of like with our opioids, we've had these synthetic opioids develop. We've had kind of an industrialization of the marijuana kind of industry, where they now are genetically engineering more and more potent strains, and the drug potency that's present today is much higher than it was 20, 30, 40 years ago.
Higher. And have you seen patients go into any type of psychosis from marijuana?
I have. I've seen profound paranoia, psychosis. I had a young patient who was an athlete who kind of, some of his friends were using marijuana, and he had profound panic attacks that lasted actually for several months after his single use of that. And that's not typical, but for him, that was profound, and it really impacted his sports that year. And he just, when he would get into his game, that was in his mind, and he couldn't shake it. It was really challenging for him. But after probably about 4 to 6 months, he was able to make some progress and done a lot better.
So one use of marijuana costs 4 to 6 months of panic and anxiety attacks. Yeah. And was this person under 21?
They were. So we see that typically in younger people that can have more profound effects, and it can impact not only their school performance, but kind of how they interact with their friends, and they do in their social support networks. It can affect with their family life as well. So I really think making sure people understand the risks of it, especially since it's so prevalent now, and people talk about doing edibles or doing things on a regular basis. It's become normalized, and I think people just need to understand the risks. And I do the same thing with alcohol because alcohol is probably the most common drug of abuse that I see in my practice. But overall, having a message of prevention, providing information so that patients can make their best decisions for themselves. And usually when they have the best information, they tend to make better choices. Not everyone, but I think if you have a better understanding of things, there's a better chance that you'll make the right choice for yourself.
So in a family practice, you're seeing parents of teenagers. Do you have a specific message you give them?
So I talk to parents about just having open communication, also not being judgmental. I think the more you try to control teenagers, the more rebellious that they can be. But I think
I can attest to that.
accepting them for who they are, showing them unconditional love. I know the message I gave to my daughter when she was in middle school, as moving to high school. I talked about that, a lot of people will be drinking, a lot of people might smoke or do other drugs. And I said, if you're ever in a situation, you can make decisions for yourself. But if you do make a decision and you're using something that is impairing you, call me any time of day or night, and I will be there. And I won't make you feel bad, but we'll talk about it afterwards and how do we make things better. And we'll talk about your decisions. So it was with love that I would be there because first and foremost, I care about her and I wouldn't want anything to happen to her. And then secondly, I want her to learn and grow from whatever experiences she has. And so I think having that type of proactive communication and that trusting, loving relationship with our kids, that can make a big difference where they feel more open to reaching out. If they feel like they reach out and they're going to get kicked out of the house because they used a drug or they drank too much, then they're going to be less likely to reach out for help when they really need it. And as a parent, I feel like our job is to be there for them when they need it.
I 100% agree with that. But how do you approach it since one pill can kill? One drink of alcohol usually can't kill.
That's right.
One cigarette isn't going to damn you to lung cancer. But now we're living in this world, and my children know what naloxone is. They hear me say, you can't take anyone else's pill. It has to be a pill that comes from your doctor, or you could die. So what's the message to parents? How should they talk to kids there on that specific one?
I think they need to let them know that the drugs that are available now are extremely dangerous, as you mentioned. They can cause addiction, and they can cause you to lose life even after just using it once. And so they need to understand how dangerous that is. I think sharing messages from what's happened in our community. I mean, you've talked about some overdoses in your community.
Yeah.
I think if people are aware, then they make better choices. They need to have some fear of this, but not so much so that they can't talk about it. We need to say, like, this is really dangerous. And there's ways that you can kind of get out of situations and you can make choices. Like, you are the CEO of your life and you can make the right choice for yourself, or you can make choices that are really dangerous. And I think if you think about what's important to you, then you'll make the right choice. And so if they understand how dangerous it is, I think that really helps. I think it's like with the marijuana talk we were just talking about, is that it's become normalized. Oh, people just pop pills. Like, for a number of years, I was hearing that teenagers were saving and selling their Percocet after they had a dental procedure, and they were selling it to their friends. And so they thought, it's not a big deal. It's just a pill. Doctors prescribe this. I think what's different now is that this isn't prescription medication. There's no quality control. You have no idea what you're putting in your body if you choose to use drugs that you're getting now. And more often than not, there are these combinations that can cause you to lose your mind and maybe lose your life.
That's a great way to put it. So we have 5 minutes left, and we're going to have 2 questions that we got to get answered. You touched upon Medicaid just briefly, and they really didn't get to expand on it at the panel. But there have been 3 announcements of healthcare and hospital closures in New Hampshire due to the sweeping Medicaid cuts from the One Big Beautiful Bill. And these facilities have served, according to the Boston Globe, some of the state's most vulnerable residents, many of them who already face transportation barriers and limited access to care. And I'm quoting from the article. So with closures like these on the horizons, what ripple effects do you expect for overdose prevention, emergency response, and recovery in New Hampshire?
So I'm really concerned about what's happening with Medicaid. In New Hampshire, it was like, I think in 2014, we expanded Medicaid. I was part of the commission that worked on expanding that. It was a kind of a legislative commission that involved people in the community, and I was lucky enough to be part of that. And in New Hampshire, we kind of came up with our own way of doing it so that it would cover people in a way and make it accessible for them. And we were really proud of that work. Our former governor, Governor Sununu, has cited that Medicaid expansion was the single most important tool in his tool belt of addressing the opioid crisis because it provided people with addiction treatment. It expanded our treatment provider pool because we had funds to support that. And it saved lives. And so Medicaid saves lives. And if we make cuts in Medicaid, we're definitely going to see people die as a result of this. I think the other part that's going to happen is that people, as they lose coverage, are going to forego primary care, and they're going to get sicker, and they're going to show up in the emergency departments with a wide range of conditions. And then if you throw on top of that, if we are cutting back on life-saving treatments for substance use disorder, we're going to see people using and showing up in the emergency department at higher numbers. And this trend that we've seen nationally with a reduced death rate, I think I'm afraid that it's going to reverse. And I think with these other synthetic drugs, we're going to see more and more people present for longer stays in the hospital, more psychosis. And we almost have like a perfect storm between we're losing coverage for treatment. It's going to impact training health centers where we train physicians to care for our communities, but also to provide life-saving treatment for substance use disorder. So it's impacting our workforce. And then it's also impacting how busy our hospitals are going to be, because if they can't go to a community health center or they can't come to my practice, they're going to end up in the emergency department, and it's going to congest things. And we thought the things that were bad in COVID with congestion in the emergency departments, I think it's going to actually get worse.
So we're going to end with this one last question. If you could get one message across to policymakers or elected officials about addiction, what would it be?
So my message to anyone who's interested in working on this is that people with addiction are people just like you and me. It can happen to anyone, and we need to have empathy and care for them, and so they get the right type of treatment, and so that they can get into recovery. I think that's so important, and I have this fundamental belief that people can change, and people do change, and especially when they're well supported. I also think it needs an ecosystem of multiple players to solve this crisis. We can't just treat people out of this crisis. We can't arrest people out of this crisis. We can't just focus on prevention. We need to do all aspects of it. And I know there's been a lot of emphasis on law enforcement and cracking down on the drug cartels, and that is really important. But we can't do that alone. We need to focus on prevention to get those messages out to kids and families. We need to focus on treatment so that people in recovery now can stay in recovery and not relapse as they lose their health insurance. So we need to support all aspects of our ecosystem that is designed to treat the opioid crisis, and that includes treatment, law enforcement, prevention, and we also need to have good data systems so that we can be responsive to what's happening. So that's all part of that same ecosystem, and if we keep that robust, we will see improvements in what we're seeing in our communities. If any aspect of that starts to fall apart, I'm really worried that things will get worse. I know people care about this, and I know that when people understand the magnitude of this and who it affects, because it affects all of us, if it affects all of us, then we all should be part of the solution.
Amen. Well, thank you for your time and coming on the Poisoning Podcast, Dr. Harker.
Thank you, Erin.